Diaper dermatitis, also called diaper rash or napkin dermatitis, is the most common skin eruption in infants and toddlers. It typically occurs on the convex skin surfaces that are in direct contact with the diaper, including the buttocks, lower abdomen, genitalia, and upper thighs. Although diaper dermatitis is a form of irritant contact dermatitis in most cases, eruptions in the diaper area may represent exacerbations of more diffuse skin diseases such as seborrheic dermatitis or atopic dermatitis, or may be the manifestation of unrelated skin conditions that coincidentally manifest in the diaper area. The reported prevalence and age of onset of diaper dermatitis in infants varies worldwide in relation to differences in the diaper use, toilet training, hygiene, and child rearing practices in different countries. It develops as early as 1 week of age, but the peak incidence occurs between 9 to 12 months. Several factors are involved in the pathogenesis. Excessive moisture. The increased moisture in the diaper area due to combination of occlusive effect of the diaper with the presence of fecal or urinary waste leads to maceration of the skin and disruption of the stratum corneum. Friction. Maceration increases the susceptibility to frictional damage from the diaper with further impairment of skin barrier function. An altered skin barrier then permits increased permeation of chemical irritants and microorganisms. Fecal enzymatic activity and pH increase. The primary chemical irritants in the diaper area are derived from the synergistic action of urine and stools. Fecal bacteria produce the enzyme urease, which interacts with urine to increase the pH level beneath the diaper. Elevated pH level activates the fecal enzymes like protease and lipase that directly irritates and damages the skin, causing an inflammatory skin reaction. Increased skin pH and change in skin microbiome. The normal acidic pH of the stratum corneum has an important role in the formation and maintenance of permeability barrier and in the antimicrobial defense. The elevated pH due to fecal enzymatic activity alters the cutaneous microbiome, making the skin more susceptible to colonization by the organisms commonly found on the skin surface. For example, Staphylococcus aureus and Streptococcus pyogenes, etc. All these factors lead to local disruption of the skin barrier function and cause diaper dermatitis. A variety of risk factors may increase the risk of diaper dermatitis, like immature skin barrier function, infrequent diaper changing, diarrhea or chronic stooling. Infants with diarrhea or chronic stooling have an increased risk of developing diaper dermatitis due to continuous local skin irritation. Dietary factors also may play a role, like breastfed infants have a lower incidence of diaper dermatitis than formula-fed infants, possibly because breastfed infants have a lower stool pH. Recent use of broad-spectrum antibiotics may predispose infants to develop diaper dermatitis by increasing the risk of developing diarrhea and secondary yeast infections. Clinical features. Irritant diaper dermatitis typically occurs on the convex skin surfaces that are in direct contact with the diaper. These locations include the buttocks, lower abdomen, genitalia, and upper thighs. The skin folds areas are not in direct contact with the diaper and are classically spared. Diaper dermatitis presents with intense erythema, macules, and papules, often coalescing into plaques, edema, and scaling in the involved areas. Superficial erosions may be noted in severe cases. In infants with darkly pigmented skin, the erythematous skin may appear deep red to violaceous or hyperpigmented. Scaling areas may appear hypopigmented. Classification of diaper dermatitis. Mild diaper dermatitis is characterized by scattered erythematous papules or mild asymptomatic erythema over limited skin areas with minimal maceration and frictional irritation. Moderate diaper dermatitis is characterized by more extensive erythema with maceration or superficial erosions, Pain and discomfort are associated symptoms. Severe diaper dermatitis is characterized by extensive erythema with a glossy appearance, painful erosions, papules, and nodules. The clinical course of diaper dermatitis is typically episodic. Each episode of mild to moderate diaper dermatitis treated with conventional therapy has an average duration of 2 to 3 days. Diaper dermatitis that persists for several days despite standard treatment may be secondarily infected with Candida albicans. If irritant contact dermatitis, that is diaper dermatitis, is left untreated for more than 3 days, it may become secondarily infected and cause one of the 4 complications. Candida superinfection classically presents with beefy red plaques, satellite papules with superficial pustules that leaves a collarate of scale once ruptured. In contrast to simple irritant diaper dermatitis, Candida infections commonly involve the skin folds. There also may be a history of diarrhea, recent antibiotic use, or oral thrush. Diagnosis is usually based on the clinical presentation but may be confirmed by potassium hydroxide preparation demonstrating pseudohyphae or by fungal culture. Persistent Candida diaper rash in young children may be a sign of disorder that increases the susceptibility to Candida infections such as type 1 diabetes mellitus, chronic mucocutaneous candidiasis, or an underlying immunodeficiency. Secondary infection from Staphylococcus aureus or Streptococcus pyogenes may also develop in the diaper region, the hallmarks of which include impetigo, 1 to 2 mm fragile pustules, and honey-colored crusted erosions. Bullous impetigo describes large flaccid pus-filled bullae that tend to rupture easily, leaving erosions with a collarate of scale. Gram stain and bacterial culture of a pustule should be performed to confirm the diagnosis. Infants with bacterial diaper dermatitis who are febrile or have systemic symptoms like irritability, lethargy, or hypotonia require additional evaluation and treatment. Perianal streptococcal dermatitis in infants and children may manifest as a superficial skin infection in most cases caused by group A streptococcus. It is characterized by bright red, sharply demarcated perianal or perineal erythema, sometimes associated with perirectal fissures, blood-streaked stools, pruritus, and pain with defecation. Some children present with intermittent episodes of irritability. The patient or household contacts may have a history of recurrent streptococcal pharyngitis. Herpes simplex virus infection may manifest with clusters of vesicular, papular, or pustular lesions in the diaper area. Herpes simplex virus infection in the diaper area is a possible manifestation of child abuse. The diagnosis of diaper dermatitis is made clinically based upon the presence of an erythematous eruption that involves the convex surfaces of buttocks and genital area. In children with darkly pigmented skin, erythema may appear dark brown or violaceous instead of pink or red as typically seen in patients with lightly pigmented skin. The sparing of skin folds is characteristic of irritant contact dermatitis unless there is Candida superinfection. The differential diagnosis of diaper dermatitis is broad and includes multiple conditions. Infantile seborrheic dermatitis is characterized by well-circumscribed erythematous papules and plaques with greasy yellow scales most prominent in the skin folds. In the diaper region, the inguinal creases are mainly involved. Seborrheic dermatitis is rarely isolated to the diaper area. Most infants also have involvement of the scalp, face, neck, and other skin folds like axilla, antecubital fossa, and popliteal fossa. It usually responds to short-term topical therapy with low-potency corticosteroids or topical antifungal preparations. Atopic dermatitis usually spares the diaper area since the diaper provides a moist environment that hydrates the underlying skin, preventing the development of eczematous dermatitis. When the diaper area is affected by atopic dermatitis, signs of chronic scratching like Increase in skin lines and excoriations may be observed. Atopic dermatitis is usually present elsewhere on the body, and there is typically a history of pruritus and may be a family history of atopy. Allergic contact dermatitis is an uncommon cause of dermatitis of the diaper area. Diaper dyes, fragrances, elastic bands, and adhesives are the sensitizing allergens in diapers. Preservatives, fragrances, and additives in baby wipes and topical creams have also been implicated. Heat and moisture associated with diaper use may facilitate allergen release and absorption into the skin. Psoriasis can appear at any age and may initially develop in the diaper area. It usually presents with sharply demarcated erythematous scaly papules and plaques in the diaper area. Significant scaling may be lacking in involved areas in the diaper region due to the presence of maceration and moisture beneath the diaper. There may be a family history of psoriasis, and erythematous plaques with scale may also be noted elsewhere on the body. Scabies can involve the diaper region in infants. An acute widespread pruritic dermatitis is the most common manifestation. Cutaneous findings include a widespread vesicopapular eruption involving the trunk, axilla, neck, palms, and soles. Other family members with similar lesions and a history of pruritus support the diagnosis, which is confirmed by identifying a mite, egg, or stool on microscopic examination of a scraping from a lesion. Langerhans cell histiocytosis is a potentially life-threatening neoplastic histiocytic disorder that can present as a severe or recalcitrant diaper dermatitis. The cutaneous lesions usually present during infancy or early childhood and consist of red or orange or yellow-brown scaly papules, erosions, and petechiae, most commonly in the groin, intertriginous lesions, and scalp. A skin biopsy is necessary to confirm the diagnosis. Child abuse is an important consideration in severe recalcitrant or atypical diaper dermatitis. A severe diaper dermatitis that appears resistant to treatment may be the result of neglect by the parent or caregiver. The diaper area is also a possible site for scalds, burns, and bruises in abused children. The skin lesions in congenital syphilis may be present at or after birth. They may be seen in the diaper area and or around the mouth and nose and are characteristically copper-colored, scaly macules and papules or moist erosions. Perianal papular lesions, that is condyloma lata, may be seen. The skin lesions contain spirochetes and are highly infectious. Other manifestations include symmetric desquamation of the palms and soles, anemia, hepatosplenomegaly, jaundice, and changes of the long bones. Diagnosis can be confirmed by dark field microscopy. Laboratory tests are not usually necessary in the evaluation of irritant contact dermatitis of the diaper area. However, they may be helpful in atypical or recalcitrant cases. Potassium hydroxide preparation or fungal culture in infants with recalcitrant diaper dermatitis involving the skin fold may be helpful for confirming a diagnosis of Candida superinfection. Mineral oil slide preparation for scabies may be helpful in confirming the diagnosis of scabies. Polymerase chain reaction or PCR or viral culture can confirm the diagnosis of herpes simplex virus in infants with suspected herpes simplex infection in the diaper area. Culture of skin lesions for Staphylococcus aureus or group A streptococcus may be necessary for confirming a bacterial superinfection. A skin biopsy may be necessary in cases in which the rash is atypical or unresponsive to therapy. The management of diaper dermatitis involves general skin care measures, choice of diaper, and use of topical barrier preparations. Skin care of the diaper area. Increasing the frequency of diaper changing and skin cleansing limits the prolonged skin contact with stool and urine, and therefore is an essential aspect of the management of diaper dermatitis. Rest periods without a diaper are necessary. If possible, an infant with irritant diaper dermatitis should be allowed periods of rest without a diaper, for example, few hours per day, allowing the skin to be exposed directly to air. The diaper area should be gently cleansed with warm water and a small amount of mild cleansing product with physiologic pH. As an alternative, fragrance-free and alcohol-free baby wipes can be used but should be discontinued if the skin becomes irritated or broken down. Preservatives such as methyl isothiazolinone in baby wipes may cause allergic contact dermatitis. Powders such as cornstarch or talcum powder pose a significant respiratory risk if accidentally aspirated and therefore should be avoided. Baking soda and boric acid powders also should be avoided because of the risk of systemic toxicity with percutaneous absorption. The best choice of diapers for use in infants is a controversial issue. Disposable diapers using advanced diaper technology may be preferred during the treatment of diaper dermatitis because their high absorbing capacity minimizes the skin exposure to urine and feces. In mild to moderate diaper dermatitis, topical barrier preparations in the form of creams, ointments, and pastes are generally used as the initial therapy for mild to moderate diaper dermatitis. Topical barriers are applied with everyday diaper change. They should be applied thickly and can be covered with petroleum jelly to prevent sticking to the diaper. Barrier preparations physically block the chemical irritants and moisture from contacting the skin and minimize the friction. Pastes and ointments are generally better than creams and lotions, which are poorly adherent, minimally occlusive, and may contain fragrances and preservatives. The most common over-the-counter topical preparations contain petrolatum, zinc oxide, or both. Some also contain lanolin, paraffin, or dimethicone, a silicone oil. Human breast milk is thought to have an anti-inflammatory and antimicrobial property. Breast milk is as effective as 1% hydrocortisone cream in clearing the rash after 7 days of treatment. Topical barriers are medications that contain fragrances, preservatives, and other ingredients with irritant or allergic potential like neomycin should be avoided. Products containing boric acid, camphor, phenol, benzocaine, and salicylates should also be avoided because of the potential of systemic toxicity and methemoglobinemia. For cases of severe diaper dermatitis, low-potency topical corticosteroids such as 1% hydrocortisone can be used for severely inflamed irritant contact dermatitis that does not respond to skincare measures and use of barrier preparations. They are applied twice a day for 3 to 5 days concomitantly with barrier preparations. Barrier preparations should be applied last. Potent or fluorinated corticosteroids should not be used in the diaper since the occlusion in the area promotes systemic absorption and may cause adrenal suppression and iatrogenic Cushing syndrome. When we suspect Candida superinfection, a drug can be used for its treatment in following 3 scenarios. When there is clinical evidence of Candida superinfection like beefy red plaques, satellite papules, superficial pustules, or involvement of skin fold. When Candida superinfection is confirmed by potassium hydroxide preparation or a fungal culture. Dermatitis that has been present for several days, which increases the likelihood of secondary infection with Candida. In such cases, a topical azole antifungal agent like miconazole, clotrimazole, or iconazole can be used for treatment. Topical antifungals are applied to the diaper area beneath the barrier ointment 2 to 3 times a day until the rash has resolved or up to 2 weeks. Potential adverse effects of topical antifungals include irritation, burning, and itching. Combination topical corticosteroids and antifungal creams such as betamethasone dipropionate and clotrimazole cream or triamcinolone acetonide and nystatin cream should not be used in the diaper area because both contain topical corticosteroids that are too potent for infant skin and may cause unwanted corticosteroid side effects such as skin atrophy and adrenal suppression. If a secondary bacterial infection is present, topical or oral antibiotics may be necessary. For localized infection, topical mupirocin is applied twice a day for 5 to 7 days, which may be sufficient to treat a staphylococcal infection. Oral antibiotics are indicated for more severe infections, including perianal streptococcal dermatitis. Neosporin ointment should not be used because it contains neomycin, which is a common inciting agent for allergic contact dermatitis of the diaper area. Similarly, bacitracin ointment should be avoided. In children with recalcitrant diaper rash that does not resolve with standard treatment, non-diaper associated causes of dermatitis or underlying conditions that predispose to diaper dermatitis must be considered. Additional laboratory testing or a skin biopsy may be required for precise diagnosis. Persistent candida diaper rash in a young child may be a sign of type 1 diabetes mellitus, chronic mucocutaneous candidiasis, or an underlying immune deficiency. For prevention of diaper rash, frequent diaper change is necessary. Based on clinical experience, the most effective way to prevent a diaper dermatitis is to minimize the direct skin contact with urine and feces by frequent diaper change and gentle cleansing of the diaper area. Disposable diapers have been designed specifically to mitigate the factors that predispose to irritant contact dermatitis. Disposable diapers have an absorbent gel core that can absorb up to 80 times its weight in water and outer layers that absorb liquids quickly and prevent liquid from leaking back out of the diaper on the skin. Overzealous cleansing can promote irritation and delay skin healing. Limited gentle cleansing with warm water and a soft cloth are usually sufficient. If soaps are desired, mild fragrance-free liquid soaps may be used. If the diaper area is eroded, it may be irrigated with warm water from a plastic squeeze bottle or by squeezing a washcloth soaked in warm water. Dried feces can be gently removed with mineral oil applied to a cotton ball. It is not necessary to wipe off barrier paste completely at each diaper change, but when removal is required, mineral oil is helpful. To avoid unnecessary friction, the diaper area should be dried by gently patting with a towel. Infant wipes are widely used for practical reasons, although there is limited evidence from randomized controlled trials that they are gentler than water for cleansing the diaper area. Fragrance-free and alcohol-free baby wipes are preferred. Baby wipes containing preservative methyl isothiazolinone may cause allergic sensitization and should be avoided. Educating parents or caregivers in ways of preventing and treating diaper dermatitis is of utmost importance. Providing educational materials or handouts can be helpful since it allows families or caregivers to review the information again at home.